Yeah, sure.
Do that since you probably have a
Yes,
published piece.
exactly.
Anything specific you want me to say or not say?
No, whatever is fine. I'm glad for you to refer to me as a hometown boy. That's fine.
So good afternoon, everyone. I think we'll get started. Welcome to Pediatric Grand Rounds. A couple of housekeeping items before we get started. Please make sure call the number in the back with the event ID number because that's how we count our numbers of who's come to Grand Rounds. It will also get you CME credit, so if it's the first time you're calling in with your cell phone, you will get a text back from CME identifying your cell phone number, and then they will give you CME credit for it. But even if you do not need the CME credit, our students and residents, please do sign in with that number because, like I said, we need that for accreditation of Grand Rounds. Also, if I can please remind everybody to complete your evaluations at the end of the session. Again, a very, very critical piece for the CME accreditation. For us to be able to continue Grand Rounds next year, I need everyone to please sign in an evaluation. So having said that, I welcome you to our Pediatric Grand Rounds. I'm very, very excited to have Dr. Jackson Williams here with us. He is visiting us from Bay State Children's Hospital in Boston. Dr. Williams is division chief at Pediatric Hospital Medicine there in Bay State Medical Center, Tufts, as well as the medical director for the Peds Hospitalist program there. And I think a med Peds background, is that right?
Yes.
He is actually, I should say, a hometown boy. So originally a hilltopper from Johnson City, did his bachelor's from Wake Forest and then went on to do medical school in Memphis, following which we lost him to Bay State Medical Center, I guess, where he did his residency. And so you can see his connection with us here in Johnson City. But one of the reasons I'm very, very excited that he's here is really because of his global health work, which was the focus of our talk here today. He has made numerous trips with residents, students, and has taken them on trips to Liberia as well as Haiti more recently, I understand. He has done some work with tropical medicine and actually got his tropical medicine degree from Liverpool, has won numerous awards and accolades. I think his CV is so long, if I started to list it, we could take up all of our Grand Rounds time. So suffice to say, he got the Humanitarianism Award from Bay State in 2012, multiple faculty teaching awards. We just got a little glimpse of his wonderful presentation to the residents at 11 o'clock. So I'm very excited to hear Jackson. Thank you.
Thank you. Well, thanks for having me. It's nice to be back home, as it were. So this is probably going to be a little bit of a departure from y'all's typical Grand Rounds in the sense that what I'm really talking about is models of care and talking a bit about global health as opposed to, a specific disease process, talking about Chagas disease or something like that. This is really focused on models of care. So the title of the talk is Beyond Medical Tourism, Models for Sustainable Global Health, but actually I probably should have titled it Models for Sustainable Health, because I think we're still figuring this out. And one of the themes of this talk is sort of trying to be thoughtful about ways that we deliver care in global health and in low resource settings, and try to think, are there better ways that we can do it, and what are the impacts we're having when we go abroad to do work. I have no financial or disclosures or conflicts of interest. So the outline of the talk a little bit, where we're going, I'm going to talk a little bit about why I think global health is important, including to folks here in Johnson City. Kind of my background in global health, then talk a little bit about the global health landscape, the agencies involved, how different people may serve abroad, and sort of the good, the bad, and the ugly of that. And then really give you hopefully some guidance and some ideas about ways that we can practice global health responsibly. So why global health? Why is this important? So I'm going to give you a few reasons why I think this topic is important. Has anybody seen this before? This is World Mapper. Has anybody gone to this website? This is a fascinating website that's a lot of fun to play around with. But what they do is they take this map of the world that you can see before you now, and they change the size of countries in the world based on different parameters put into the software. So it may change the size of a country based on different factors. So for instance, if you look at the world's population, not surprisingly, places like India and China really blow up quite big, right, in terms of their geographic size. Poor little Canada and Russia shrink down to like little minuscule places when you think about their geographic size and their population. But this is why global health is important to me. And this is the mortality of children 1 to 4 years of age throughout the world. And you can see the vast burden of disease is really in sub-Saharan Africa. India is quite large. This is a little bit older data. This is early 2000 data, like 2002, 2003. India's made great strides and so is doing much better now. But you can see where the burden of childhood disease and childhood mortality really is. And then the next slide is the reason that I feel it's so important for us to get involved with this. This is the physician workforce. So if you look at Africa in the previous slide, where the burden of disease is, and look at what happens to Africa based on this software algorithm, you can see that it essentially disappears from the map. And that, more than any statistic I can show you, I think hopefully illustrates why there's such a need for doctors, nurses, and other healthcare workers to consider getting involved in global health. But maps like that don't always influence hospital administrators and such, so sometimes you have to think of other reasons why this topic is particularly important. And this is a nice study. It's a little bit older, but it came out in 1999, and it was at Yale. And what they found is when they started a international health track in their internal medicine residency program, they actually found that participants compared to non-participants were more likely to work in public health and in academic medical centers than in private practice. And in fact, they found that people who did the international health tract, residents who did this tract, were more likely to have patients on public assistance than those who weren't. And so nice study with that. This is a similar study that was done with the Cincinnati Family Practice Residency Program, and similar results. The residents who did a global health track were more likely to stay and take care of underserved populations here in the US. Now you can criticize these studies a little bit. Was this a chicken or an egg phenomenon? Were people, who had more of an interest in doing these sort of things attracted to these tracks, and so then they stick with underserved populations? But I think it helps to keep people's compassion levels high and empathy high, and keep people interested in taking care of underserved populations. But if those arguments don't sway you, the other argument I'll put forth is this one. Anybody have an idea of what this picture may represent? So this is the family of a little 2-year-old boy named Emil. And Emil grew up in a very small village in Guinea. And Emil liked to play in a tree trunk where lots of bats were roosting. Emil, who you can't see sort of off to the side, died of a mysterious illness a little over a year and a half ago. And his mother and his baby sister ended up dying from the same illness. And this is Emil's father who's holding these pictures. Any idea what illness that might be? Ebola. So Emil is thought to be the index case for the Ebola outbreak that we've seen in West Africa, and has actually touched all of our lives here in the US. And I think now that we are a global community, we have to remember that the next potentially significant epidemic may be just a plane ride away. And so this is another reason that it's really important for us to educate ourselves in global health, because whether you believe it on a spiritual and existential and metaphysical level that our fate is connected to a 2-year-old boy in Guinea, at least I think folks can understand from a very real public health and practical matter, our fates are very much tied to what happens to a 2-year-old child like that. I want to briefly just talk, particularly for our learners in the crowd, how I sort of got involved in global health. I'm always a little bit skeptical of speakers who spend a lot of time talking about themselves, but I just wanted to share a bit about how I got involved in this work, share a little bit about that, and I want to indulge myself a bit because it really started here in Johnson City. So most people may recognize that. That's St. John's Church around the corner from here. And the first time I really think that I got involved in this sort of work was working as a 11th grade high school student with this Appalachian Service Project, and going out and living and working, building houses with communities in rural parts of the Appalachian Mountains, and sort of seeing what other people's lives were like, and that's what really attracted me to this work. So I think that this work is not mutually exclusive of doing good work here for rural and underserved populations here in East Tennessee. I think it's actually complementary, and so that's why I wanted to sort of share this with you. But my first trip abroad was actually to India, where I worked several times. This is from the Johnson City Press about 20 years ago. But again, the title sort of says it all. It was indeed a life-changing experience. On that trip, I got to work with Mother Teresa's Missionaries of Charity, which really continued to fuel my interest in doing global health work. And this is really important, but I kept returning to the same site. So I went to Calcutta 4 times during college, medical school, and residency. And I think if you get involved in this work, I think it's really important if you can go to the same location and continue to do that sort of work. After residency, I got very involved with starting our hospitalist program, and so I had to put global health on hold. But then I decided it was time to get back into it, and I did a sabbatical year. And one of the things I did during that sabbatical year was to get the diploma in tropical medicine. This is a 3-month course. It's offered at both Liverpool and London. There are courses in the US, but the ones at Liverpool or London are the oldest and probably the most rigorous. It's 3 months of really intensive study. You're going to class from 9 a.m. to 5 p.m. Monday through Friday. There's big tests at the end, but it's a really great experience if you have an interest in this field. And from there, I ended up working in Liberia, which is here in West Africa, which many people have, again, become more familiar with the geography of this as a result of the Ebola outbreak. So I first went to Liberia in 2012, and Liberia is certainly one of the poorest countries in the world. Before the Ebola outbreak, Liberia was best known for its years of civil war, unfortunately. And they had terrible civil wars for at least 14 years. That was the whole thing with Charles Taylor, with Blood Diamonds, and the country was absolutely in ruins afterwards. At the end of the war, there was no running water anywhere in the country. There was no electricity except for by power generator anywhere in the country. And Liberia remains one of the poorest countries in the world, and one of the least developed. And again, we talked about, I showed you the map of the healthcare workforce, but after the war, and still to this day, there's probably less than 1 doctor per 100,000 population. Here in the US, we have over 250 times that number. So you can imagine the challenges that they face. And this is where I primarily work. This is Redemption Hospital. It's on the outskirts of the capital of Liberia, so it's on the outskirts of Monrovia. And it's a, sort of single-story building that's been built out over time. And this is, the neighborhood right beside the hospital. And on my most recent trips, I stayed right beside the hospital grounds, but really slums as far as the eye can see. And this is our emergency room, which was an incredibly, incredibly busy place. This is one of our residents who recently graduated, who's actually in Sierra Leone now as an ID fellow, helping to deal with the Ebola outbreak. But you can see her finding any spot she can to do her documentation in the busy emergency room. And again, conditions that are hard to imagine here, but pretty common to have 3 kids sharing a crib together, and you don't know if those 3 babies, one may have malaria, one may have measles, one may have meningitis, and they're sort of all right there together. So that's a little bit of the background, and I'm going to use Liberia as an example in some of what's going to follow, so that you know where I'm coming from. So what does global health look like in 2015? So anybody can think of somebody who's been an important policy leader or has really set the agenda in the 21st century for global health? Hillary Clinton, the Clinton Foundation has done a lot of good. They absolutely have. I just for simplicity, I call this slide Bush, Bill, and Bono. Only a little bit tongue in cheek, but George Bush, I I've been in New England perhaps too long because he's not my favorite president, but I do have to give him credit because he did amazing work with the PEPFAR program, which I'll talk about here in a moment. Bill Gates and the Gates Foundation has really been a game changer when it comes to global health and the progress we've been able to make in the last 10 to 15 years. And Bono, a little bit tongue-in-cheek putting him in there, but he's done a lot to help with African debt relief, which has had a big sort of impact on economies in Africa being able to pull their way out of poverty. So when you talk about global health and you talk about all the different organizations that are involved, it very quickly gets into alphabet soup. I don't know why global health people love an acronym, but they really, really do. So I'm going to talk about some of these, but not all of these. There are different agencies like the UN agencies. I'll touch on that just briefly. And then there's bilateral organizations. A bilateral organization is one country giving aid to another country. And then there's NGOs or non-governmental organizations. More recently, we've been seeing public-private partnerships, particularly with the Gates Foundation and the pharmaceutical industry, partnering with the UN and with countries to sort of improve health. And then there's academic medical centers. Where do we as academic medical centers fit into this mix? There's, of course, faith-based organizations, and even the military is often involved in global health and providing health care in low-resource settings. So the United Nations agencies, I'm not going to go through all of these, but it's just interesting to think about and understand that there's all these different groups, most of which are involved in healthcare in one way or another. There's, of course, UNICEF, which deals with children's issues. There's the Refugee Agency, the World Bank, but all of these tend to really touch on healthcare in one way or another. And they sometimes work well together, but they often work in silos. And so that's one of the challenges that we face, sort of big picture-wise, how global health works. But let's talk about the World Health Organization, because obviously that's the one that people sort of talk a lot about. What a lot of people don't understand or realize about the World Health Organization is that they don't implement healthcare. They don't even fund healthcare. They really just set policy and standards and the international agenda. They do monitor trends in illness, but they don't do anything in terms of going out and fixing problems throughout the world. And they have a very small budget. How small a budget? Well, the current budget for the World Health Organization is about $2 billion per year. And actually, there was this interesting article on NPR that they had pretty significant cuts right before Ebola happened in their outbreak preparedness. Just by $2 billion sounds like a lot of money, certainly to me. But compare that to what the U.S. Internal Revenue Service annual budget is of $13 billion per year. And the U.S. Annual military spending is $600 billion per year. So if you think about our society as a global whole and a global good, we've really underinvested in our international public health resource in a lot of ways. But there are other avenues. Oh, I'm sorry, we had to transfer slides, so there may be a couple of transfer issues. But bilateral organizations or bilateral aid. So that's, again, one country giving aid to another. So the main arm for this in the U.S. is USAID. And again, one of the things people have to realize about this is an arm of American foreign policy. Funding comes from Congress. They report to the Secretary of State. And you can see in 2012, the countries who got the most funding were really more for political reasons than where the biggest issues are. Afghanistan, Pakistan have really significant healthcare issues. There's no doubt about it. But they get, the bulk of the funding and are in the top 3 recipients, and countries in sub-Saharan Africa tend to be much lower. Jordan is actually classified by the World Bank as a middle to an upper middle income country. So, it's just kind of interesting how this sort of plays out. And this is really not just an aid beneficial thing that our government does. This really has political strings attached to it too. But again, one of the success stories, and this is a part of what USAID does, is PEPFAR. And that's the President's Emergency Plan for AIDS Relief, started during the Bush era. And since that time, going to September 2011, there have now been 4 million people enrolled on antiretroviral therapy to treat HIV and AIDS. And again, this has really made a huge difference in people's lives. The challenge with this is going to be continuing to sustain the funding. Now we have all these people on ARVs, and more, as you know, we're managing HIV and AIDS as a chronic illness. And so these people are going to need their medicines for quite some time. So let's move from bilateral aid and talk about NGOs or non-governmental organizations, which a lot of people may have some familiarity with. So I've sort of break down NGOs into a couple of categories to sort of wrap your mind around. I think of these as NGOs that deal with disaster relief or emergency aid. MSF, or Doctors Without Borders, is probably the best example of that everyone knows. But then there's organizations that work in development. And those may be large NGOs. So large NGOs may have comprehensive programs, big multinational projects. Examples of this are like Save the Children, Carter Foundation, Clinton Foundation, that really do a lot of different things. But then there's also smaller or more focused NGOs, and they may focus on a single issue like cleft lip or palate repair that Operation Smile does. Or they may just work in a single country or for a single issue. And for instance, the group I've worked with in Liberia was really just focused on that particular country. So this is an example of all the projects for health that the Carter Center is doing. And you can see it includes things from guinea worm to trachoma to malaria. And these are all the countries where the Carter Center works. And so you can see that there are these big NGOs that have massive projects that span the globes. And then there's other, much smaller sort of non-governmental organizations involved in this kind of work. What about academic medical centers? Well, I think, we all know that the emphasis is on education, but particularly for U.S. learners, although that is changing a lot in global health. Obviously, academic medical centers can bring a lot to the field of global health in terms of research, but in terms of institutional interest, it depends on who you're talking to in the administrative chain. Sometimes you can make arguments around greater good and altruism, but this is a huge issue, as many of you guys may know, in residency and medical school for resident and medical student recruitment. It does good things for the public image, and I believe it really helps to train better doctors because you learn, as I shared with the residents at the lecture at 11 o'clock, different things in terms of physical exam skills and new skills that you can apply, not just abroad, but here in the U.S. But academic medical centers, you should also realize, often partner with NGOs so that residents and students can do work abroad. And those relationships can be quite variable, and you can see all sorts of iterations of those relationships. So at the start of my talk, I sort of gave the title Beyond Medical Tourism, and I did that to be purposefully a little bit inflammatory and get people thinking a bit. So this is a term that people in global health banter around quite a bit, and people all kind of understand this is a term that really applies to short mission trips and trips that perhaps benefit people from wealthy nations like here in the U.S. more than they benefit the poor. And so last year, when our project in Liberia was abruptly canceled because of the Ebola outbreak, I took several residents and we did a last-minute trip to Haiti for a week, which was a wonderful experience, but I would certainly classify it as medical tourism. This is the lovely villa that we stayed at in Port-au-Prince and the swimming pool where we spent 3 nights. It's the first time doing global health I had consistent hot showers. But this was all part of this NGO that we worked with, again, in the poorest country in the Western Hemisphere. But we did get out to the country and we did do some good work. We sort of set up clinics in some churches and saw, patients, whoever showed up that day. But, when you think about these sort of trips, there were 4 of us doctors traveling. We were there for 8 days. We only saw patients 4 of those days because it took so long to get from point A to point B. And we probably only saw about 100 patients. And, was that the best use of our money? Was that the best way to help these populations in these poorer parts of Haiti? And again, it's just something I think we have to sort of struggle with a bit and consider, is this the right model or approach? Are there upsides to medical tourism? Absolutely, and I think I don't want you all to walk away from this and think that all mission trips are bad, because they're not. I just think we have to really be critical of our practice, just like we are here in the U.S., and think, are there better ways we can do this? But there are some upsides to this, and I think most people who start in global health are going to start with a 1 or 2 week trip, and that's fine, and that's how I started in global health, and that's how everyone else does. You can make the argument that even if this was a pure tourist trip and we were being treated really well and we had a good experience, the money we were spending was paying for interpreters, cooks. We stayed in this very small place in Cascade Pichon, which was this beautiful waterfall in the previous slide that no other tourists came to, but we stayed in this tourist hostel and did a little bit of healthcare while we were there. And that helps the local economy. It's probably better to spend that money in Haiti than it is perhaps sitting on a beach in the Caribbean in St. Thomas. There's also, of course, the opportunity for cultural exchange. And sometimes this is the best you can do. Sometimes this is the only way you can reach really isolated rural populations that may be hard to reach otherwise. And I think you may do some short-term good for local populations. So this is an example of, it's hard to imagine a clinic being set up here. So this was one of the medical tourist trips that I took in the Indian Himalayas. And this was, we were setting up, high altitude clinics in a region that's snowbound 8 to 9 months out of the year. And so these populations lived 3 or 4 days walk from the nearest town where there was any semblance of healthcare. So you can imagine, it's really hard to imagine, really hard to picture having a clinic or, a more sustainable model of health there. So sometimes that is what you end up having to do. Is there the potential for harm, though? And again, I think we just have to think about this a little bit critically. Sometimes these trips may weaken rather than strengthen local health systems. They may lack integration with national health systems. They may compete with local MDs and providers. The most striking example of this I ever heard, I was in a global health lecture. It was actually being given by a surgeon. And he told this story of he was at this national conference for surgeons, and they were talking about this great global health work they had done, let's say in Ecuador. And they're like, we did 100 hernia repairs, and this is our data, and these were the outcomes, and it made such a huge difference. This was amazing. And apparently a small gentleman in the background sort of raised his hand. He said, excuse me, sir, where did you say you were exactly in Ecuador? Oh, okay, I thought that's what you said. And you were there in April, right? Okay, yeah. So I'm a surgeon in that village, and I was wondering where all my patients went for the month of April. They just vanished. And you think, boy, we may think that we're going in and doing good, but that weakens the healthcare system and it weakens the local providers. How much better would it have been if that surgery team had gone there and said, hey, let's work together. Let's do some cases together. Maybe you can show me a few things I don't know, and maybe I can show you a few things that you don't know yet. And so I think just being thoughtful about those things is really important. The big criticism of short-term trips is that there may be poor continuity of care, that they may lack sustainability if you're doing the quick fly in for a week or two and leave. Who's there taking care of the patients once you're gone? And I think those are important questions to ask. And participants may be unfamiliar with local culture, disease, and best clinical practices. So what's the biggest challenge to healthcare for the world's poor? I might argue that this is the biggest challenge, that there are so many groups now working and involved in this work that it can get really confusing very quickly. This can cause massive fragmentation of care and projects. Duplication of projects is really quite common. There's often poor coordination. There's also very much with this approach a top-down approach. So we're coming from the Western country, we know what's best for you in Liberia, and this is how you're going to do it, as opposed to partnering with people locally. And then there's often poor country ownership because all of these projects are owned by folks living in wealthy countries. There's often high transactional costs, and by that I mean it cost a lot for my team to fly into Haiti. It cost a lot for them to drive us around and get us to these clinic sites that were in these rural communities. And if we could have figured out a way to foster healthcare in those communities more sustainably, perhaps those costs wouldn't have been there. And there can even be competition. Not just with local providers, but I've heard of NGOs having arguments over who gets to immunize that village over there, because I report to my donors back home in America, and they want to see by God that I've immunized 500 kids in this village. And so there's often these conflicts that come up. But to make it a little bit more real, and I shared this case with the residents earlier, this is a patient that I encountered in Liberia who experienced some ill effect because of this fragmentation. But she's a 5-year-old girl who had repeated bouts of fever, and increasing abdominal girth. And when I lifted up her shirt, she had massive hepatosplenomegaly. That is actually her spleen coming all the way around, as well as her liver. I ultimately diagnosed her with schistosomiasis, which can do this. It's a fluke. It lives in your mesenteric plexus. It's a neglected tropical disease. So just to tell you how this girl came to the hospital, she came to Redemption Hospital where I'm working. She saw some physician assistants, and they had been trained by Doctors Without Borders and actually had really good training. But that training was 10 years ago during the years of Civil War, and Doctors Without Borders had long ago left, but those PAs hadn't really gotten much training since then. So they were sticking to those 15-year-old guidelines that they had first gotten from Doctors Without Borders. I'm working there for a particular NGO. My partner, who's a Uganda doctor, is working for a completely different non-governmental organization, but at least we worked well together. This hospital that we were working in, Redemption Hospital, was actually built in phases. And so the ward where we were was built by Mercy ships. Then the ward sort of beyond that was built by the US Navy, actually. There was another ward that was built by another agency, and it was sort of this hodgepodge of buildings and groups working there. Because she had schistosomiasis, I couldn't find the right medicine to treat her. I needed praziquantel, which I couldn't find anywhere in the hospital. If she had had HIV, she could have gotten state-of-the-art antiretroviral therapy through PEPFAR. We had a great PEPFAR program at our hospital, but she didn't have that. So I had no way to get medicine for her, which was actually a pretty affordable med. We just couldn't find it. And we even looked at a couple of the pharmacies that were in town to see if we could find it. And then I discharged the kid because there was nothing else I could do for her. And about 2 or 3 weeks later, I'm walking by the adult medicine pharmacy, which was run by actually the Ministry of Health as opposed to being run by an NGO, and I found a huge bottle of praziquantel that I had no idea was there. But unfortunately, because there was so much fragmentation, and this part of the hospital was run by this group, and that part of the hospital was run by that group, I wasn't able to get this child the medicine she needed. So that's why I worry about this fragmentation that we often see in low-resource countries. So can we do better? And are there ways and methods that we can do better? So there have been some developments which I think tie together a lot of these pieces. So one of the nice things, and if you're interested in this field, I'd encourage you to read more about, are the Millennium Development Goals. The one good thing about these is that it really united all these NGOs that are working in different fields to, all right, this is what we need to work towards. It was started at the UN Development Summit in the year 2000, started with baseline data from 1990, and then set targets from 2015. And these are the main goals that they were working towards. And there's a lot of sub-goals that you can look at too, which I will not go into great detail of. But I do want to talk for a moment because there's a pediatric audience about MDG number 4, which is to reduce child mortality of under 5-year-olds by 2/3. And so I think you first have to understand, why do children under 5 die? And so the graph that most commonly is shown is something like this, a pie graph. And you'd see a lot of the deaths happen in the neonatal period. And actually, I'm going to flip to the next graph, which is a little bit more simplistic. But you can see here the neonatal deaths. But kids die of really common stuff: pneumonia, diarrhea. Malaria and measles are certainly still up there, but it's usually pneumonia or diarrhea that kills these children, not something exotic, not something strange, not necessarily a fluke or a parasite. But the other factor here, and this is why I like this pie chart the most, is because malnutrition is here in the center. And this really impacts all the causes of child mortality, whether you're talking the neonatal period, or because the mothers have such poor nutritional status, or in the first few years of life. And we certainly saw this at Redemption Hospital. Kids who had malnutrition had very, very high mortality. But we are making progress, and you can see the trends in global under 5 mortality, and these are absolute numbers, even as the world's populations continue to grow. And so we have made good progress. The latest figure I saw, this was a projection that someone had done, but the latest figure I saw was about 7 million deaths in 2011 or 2012. So we've made great progress, but I think we would all agree as pediatricians that 7 million kids dying every year before they reach their 5th birthday is too many. And the other really unfortunate thing is that progress on this has been incredibly uneven. And so this was a review that came out in the Lancet to sort of see how are we doing with our progress on the Millennium Development Goals. And the countries that are in blue and green are likely to hit their Millennium Development Goal targets. So China's doing quite well. India's getting close to getting there. But the countries in red are unlikely to hit their MDG goal before 2040. And you can see again, the burden of disease really is in sub-Saharan Africa. And that's why there's so much attention paid to Africa in the global health literature. And to put this to scale and a little bit in perspective, in Liberia, it was actually a bit of a success story before Ebola happened. We were actually on task to reach our MDG by the year 2020. But one thing to keep in mind is that the MDG was for a 2/3 reduction. So Liberia has gone from being one of the worst countries in the world where 1 in 4 children die before their 5th birthday to probably more like 1 in 10 dying before their 5th birthday, which again, I think we'd still all argue is way too many. And since Ebola has happened, that number is definitely going to rise. There's no doubt in my mind about that. Not so much from Ebola itself, but from all the healthcare that hasn't happened, because for the last 9 months, we haven't been able to vaccinate children in Liberia. There hasn't been routine healthcare. The hospitals were all closed for 6 to 9 months while they were dealing with the outbreak. So it's a bit sad because Liberia was just starting to get on its feet again when this sort of second hit happened. So you'll notice the Millennium Development Goals were for 2015. Oh my gosh, it's 2015, what happens now? Stay tuned, there's a lot of talk about this in the global health literature and in conferences. The talk is now about sustainable development goals. So that's gonna be the next iteration of this, but they're still working it out. So more to come, hopefully. So where are we in 2015? There's been progress on the Millennium Development Goals. There absolutely has been, but it has been uneven, particularly in the world's poorest countries. There is often a fragmentation of projects, and I think that's something we need to be aware of. There's often a focus on disaster relief rather than prevention, and for better or worse, a lot of the international money for global health has gone to combat HIV and AIDS, and I think that's really important because it is such a significant killer. It causes orphan families, it causes all sorts of problems. But now we need to start paying attention to some of these other things like neglected tropical diseases. And the only other thing I always worry about is because this all comes a lot of times from international aid, that can be fickle, that can be subject to the whims and wills of various governments. So we've sort of talked about the big picture. We've sort of talked about how does this all play out on the world stage and what are the big issues that we're dealing with throughout the world in global health. So I want to bring it down a little bit more to the local and the individual level and talk about how we as healthcare providers, as residents, as faculty, as students can be responsible global health workers. So the first thing is, if you're going to work with a non-governmental organization, what are some things to look for? So at least from my perspective, I think you want to know, are they responsible with their funds? Is there transparency? But I think perhaps even more important than that is, do they work well with local partners? Are they integrated with the National Ministry of Health? Have they been invited to work in the region? And are they involving the local populations in their work? What is it that you need help with here in this hospital? Not what am I going to bring and tell you to do? I think it's really important that groups work well together. And then again, I've sort of touched on this, but think about, is there continuity of workforce and funds? And then really starting to move from just taking immediate clinical care of patients, but is there a way that we can build capacity? Is there a way that we can help locally to train more healthcare workers, more doctors and nurses? So can we work on education, training, and quality improvement? There's a couple articles that touch on this. This is one that I really like, and I love this title. So this was published in Academic Medicine in 2013. And this was a semi-structured interview study where they interviewed healthcare workers in Namibia who had interactions with folks coming from the US and Europe who were faculty, medical students, residents, and other learners. And they wanted to get their sense, how do you feel about medical students or residents coming to work in your hospital? And the results were actually quite positive. But what they asked and sort of the themes that developed from these semi-structured interviews was that it's really important that people who work abroad seek cultural and environmental context before travel so that they have pre-departure sessions with someone who's knowledgeable about the country and the issues. That there are long-term relationships for mutual benefit, not just 1 week a year or 1 month a year. That there's a formal needs assessment so that people really understand what the needs of the local community are. and traveling with respect, humbleness, and a desire to learn from local partners. And again, this is a quote that sort of came from the article itself, but I just love this. We learn from them, and they learn from us. I think that's a really good mindset to take with you when you go to work in this field. The American Academy of Pediatrics does have some guidance for residents who are interested in global health rotations. They really look at 4 key elements, which is that you have the prerequisite clinical training. This really mirrors a lot of the former study I just showed you, that there's good pre-travel orientation and preparation, preceptorship by host and U.S. faculty, and of course formal evaluation and feedback. Also in this study, they did some surveys of programs, and Nelson found that we weren't always doing this as well as we could. So this is something that we need to continue to improve upon. And if you really want to dive into this, there's this group that really looked at the ethics of trainees working in global health. And this is a really nice article. It's quite long, and there's quite a lot of ethical precepts. But if you want to read more, this is another resource for you. So what about our work in our model in Liberia? And this is kind of what I want to close with, and at least a way that we've tried to deal with some of these issues and try to be thoughtful about how we're doing the work. So again, I sort of mentioned Liberia was a very poor country with very few doctors, but not only were there few doctors, there were few specialists. And when I say a specialist, all I mean by that is a general surgeon, an OBGYN, or a pediatrician, someone who's done more than essentially internship training. And there were only 10 doctors like that in the entire country, and there was no pediatricians when we started in 2007. In 2007, they were just still recovering from the war, and there were very few graduates from the medical school and very few faculty at the teaching hospital. And again, I alluded to the doctor ratios in Liberia versus here in the US. So the NGO that we partnered with and worked with is this great organization. Dr. Wood has some familiarity with this, but this is the Hart Foundation, Health Education and Relief Through Teaching, which was founded by James Sirleaf, who is actually the son of the president of Liberia, so that always helps. But he founded this in 2007 and started taking 1 or 2 trips, and then more and more people got involved. And the way we got involved was by forming these academic consortia, which I think is a really nice model to help with the sustainability. A lot of times in academia, one particular hospital will say, hey, this is my project. This is the Baylor Hospital or the Boston Children's Project, and we're not going to share with anybody. And the nice thing about the consortia is that we work together. So this month, I may send my residents to work in Liberia, and then next month, Brown may send residents. And then the following month, there may be residents from Chicago. And we can all work together and have some, at least, if not great continuity, at least a regular presence there in the hospital. And one of the nice things that came out of our collaborative was that we had a lot of residents and fellows and faculty who participated, but you'll notice that particularly for the fellows and the faculty, a lot of people went back. Nearly half were repeat people who went back multiple times. And again, we were able to staff it in such a way that pretty much every month, December and July were always tough to cover, we would have some team there in the hospitals working so that they could reliably have people there on a regular basis. But we weren't just taking care of patients. What we really focused on was improving the educational system in Liberia. So we spent a lot of our time developing clinical practice guidelines, giving case conferences, doing journal club. They had never had journal club before, building the curriculum, teaching in the medical school. I've written exam questions for the national exams in Liberia. So there's a lot of different things that we were involved with to really help build the healthcare workforce and not just sort of come in and out. And as a result of this work, the medical school has seen many more graduates. I can't say that our group can take all the credit for this, but I think we certainly were the longest standing group that was sort of advising the government and the Ministry of Health and the medical school on their curriculum. And we're seeing a lot more graduates from the medical school now, which is absolutely fantastic. In addition, there's now more permanent positions at JFK Hospital, which is the national teaching hospital. Before Ebola happened, and probably still now, there's at least 5 to 10 full-time pediatricians working in the country, which is better than 0. And they're helping to train the next generation of doctors, because one of the big successes of this project was that we were able to get residency training restarted in Liberia in May of 2013. And they started with 3 residents each in pediatrics, OBGYN, surgery, and internal medicine. Unfortunately, that residency training program was put on hold because of the Ebola outbreak, but I understand from my partners in Liberia it's restarting in the next few weeks, so I'm really hopeful about that. And then because there were so many more graduates from medical school and more interns, we really worked on cultivating additional clinical sites. And that's where I came in 2012 to sort of prepare Redemption Hospital and do things like bedside teaching rounds, which had never happened at the hospital before, and trying to build up some of the educational structure within the country and within the different hospitals. Because of the Ebola outbreak, I have had to take my residents on other rotations, and most recently in February, I worked with a very, very similar group that's working in Port-au-Prince, Haiti. Again, a consortium of university and health system hospitals coming together, figuring out ways that we can provide some sustainable care. So here's some of the benefits as I see it, for this sort of academic consortium model. We're really focused on education, expansion of the healthcare workforce, as opposed to just, one day quick, throw them up clinics in a tent. A lot of focus on quality improvement, a lot of collaboration with our local partners too to figure out what they're looking for, and really building long-term relationships, which I think has been really key and important. We do strive for continuity of services, and we even have sign-out from month to month. Often the sign-out is not so much about which patients are in the hospital, although that does happen too, but it's often sign-out about what project were you working on, or what pitfalls did you have, or how did things work for you, and how can we do this better next month? And so it really builds momentum over time in terms of being able to work together. And then we've really focused, because this is all led by academic medical centers, on making sure that there's adequate mentorship, supervision, and pre-departure training for our trainees, and so that they're not just going in cold without any knowledge or skills to these places. There are critiques you can level of our model, and if I'm going to be honest, I think we should, again, still think of this critically. We have relied a lot on resident physicians, and one of the biggest challenges is often limited faculty time. Faculty time is quite an expensive thing. It's an expensive commodity. It's not as much of a challenge to get a resident to be able to do a 1-month elective and get them call-free, but to get faculty over there for large chunks of time takes some doing often. So that is one of the critiques of our model, but something, again, we try to mitigate. And we try to make sure the teams always go over with a faculty person. Now, that faculty person may only be able to stay for a week and a half or 2 weeks, but at least they're there for the beginning part of the experience. It is expensive for residents to travel abroad, and again, is that the best use of our global health dollars? I would argue yes, because I think it's critically important that we train our next generation of doctors to be really responsible and good global health practitioners, and we've got to figure out good ways to do that. So I think it's an important investment. There can still be some fragmentation of care, of course. This month it's Brown, next month it's Bay State Hospital, the next month it's Chicago, but we try to work through that as well too. And the final critique you could level, particularly in Liberia, is because when Ebola happened, there was no way that my academic medical center or any of the other academic medical centers would let residents travel to work there at a time when Liberia probably needed the help the most. And that was certainly incredibly heartbreaking to have to struggle with. Boston Children's even had a fellow who was committed to a global health fellow, to working in Liberia, who had to be pulled out of country because the institution, of course, wouldn't allow her to stay there. But we have hopefully done some good because of our long-term relationships. So our consortium was able to raise $50,000 pretty quickly. We sent over some of the first shipments of personal protective equipment for doctors and healthcare workers that got to Liberia because of our connections. And so we've tried to stay involved. And in fact, my partner at UMass has gotten a really big grant and has been over there working, not able to take residents and students at this point, but able to continue to work on getting the country to recover from Ebola. And things are looking good. There's only been one case in Liberia, at least in the last 2 or 3 months. So we're hopeful that in the next month or so, Liberia may be able to be declared Ebola-free. So just in closing, we'll sort of leave you with some ideas about how you can be a responsible global health worker if this interests you. The most important thing I'd say is just start with educating yourself. Learn about the local culture, learn about the local history and the politics, not just about the diseases, although you need to learn that too. But if you can find someone who's familiar with the country and read some good books, it will make for a much better experience. And then when you go, I think, and Dr. Jay Shankar had asked about this earlier, I think you really have to go with the mindset of, I need to learn first. I had just done this tropical medicine course when I first went to Liberia, and had spent weeks at lectures learning about malaria and all sorts of other things. But I'd only treated 1 or 2 actual patients who had malaria. So I had to really go in and say, I'm learning first, guys. I don't know about these funny medicines you're using to treat malaria. Can you show me some things? And I think going in with humility is incredibly important. And then once you do get more comfortable in the setting and you start to figure out how things work, it's a matter of sharing your ideas, not enforcing them. And I think that's really important. And being open to the needs and desires of your local partners. If you are interested in this sort of work, I think it's a great idea to return to the same region or area. For repeat offenders, you can consider doing some further education. As I mentioned, the diploma course in tropical medicine or a master's in public health is another great way to learn about this stuff. And again, continuing to work on your personal development and questioning, is this the best practice? Is there a way we can do this better? Is this a way to make this project more sustainable or to provide better continuity of care? And I think that if you keep on asking yourself those questions, things will improve over time. So hopefully you've gotten the point that global health is important and that these are important issues for all of us to consider. Global care of underserved populations is indeed improving, but progress is at times uneven, and there is indeed fragmentation of care, and I think that's one of the challenges that we need to face up to as we go forward. And we need to continue to evaluate and refine our models of global health practice and think about how we do this. And I'll close with a couple of pictures. These are some residents that I've worked with abroad, both in Liberia and in Port-au-Prince, Haiti. And these are some kids who lived in my neighborhood in Liberia. And kids will be kids anywhere, and it's always fun to take care of kids. And it should be our goal to make as many kids in the world as healthy and happy as they can be so that they can grow up to be excellent adults. Thank you. I think we've got a few minutes for questions. Yes.
You mentioned the cost of the resident traveling abroad, and so in your model, where does this cost piece come from? Is it from the hospital? Is it the residency program? Is it the NGOs that you're partnering with? Where is the...
Great question. One of the issues that some hospitals and health systems have had more struggles with than others is, does the resident still get their salary while they're gone, and who's paying that salary? We have not had that problem, and it tends to work okay if there's residency programs that are a little bit over the cap, and then you can shuffle those dollars. That's not a big deal. In terms of the resident experience itself, we actually set up, and this was true both for me in medical school and at Bay State where I am now, a grant fund. And so it's from one of our special purpose funds through the education department. And residents apply for grants, and so we have about $6,000 worth of grants we award each year, but they have to fill out an application. We sort of look at a lot of these issues like we talked about in terms of how long are you going for. So we've typically preferred to fund trips that are at least 3 to 4 weeks long as opposed to 1 to 2 week trips. And then we give the residents a grant that they can use to help offset the cost of travel and airfare. Depending on which NGO you work with, really varies the cost. So when I've worked in Liberia, they did supply housing and, lunch and breakfast. When we were in Haiti, we had to pay $100 a day to pay for housing, to pay for translators, to pay for transportation, et cetera. So it really varies quite a bit. But I think if you can find a fund within the academic medical center to support this work for residents and students, it does help because it is obviously quite expensive.
So that fund is institution-based?
Exactly, yes. Yes, sir.
Great talk.
Thank you.
Really commend you for what you have done so far. That's great. Just talking back to your experience in Liberia and how you tried to build up the medical community and a physician, any role about the healthcare worker? Because coming from India and seeing that how big role you might have witnessed they play in the different things, and because there's a barrier in this country regarding what the physician can do and what the local population can do and how they can change the perception of the community and how they can take the barrier out for clinical care, any role of training the healthcare workers or creating the force of healthcare worker which can do a great wonders that physicians cannot do?
Absolutely. So really good point. So one of the solutions for global health is, doctors tend to be top of the pyramid because we've got the most training, the most years, and it takes a lot of years and effort to train a doctor. Whereas if you can train physician's assistants and community health workers even to do a lot of this work, it can have a really big impact, especially for some of these hard to reach places that may take a day by car to get there. There is certainly some of that going on in Liberia. Our focus was really on education, though, of the medical students and the doctors. And that's what I think we brought to the table in a lot of ways. My Liberian interns and residents were much better at dealing with malaria and diarrheal illnesses than I was, but they hadn't had much education in differential diagnosis. Well, what if it's not malaria? What else could this be? And so working through those sort of problems really helped them, because the docs really need to be the ones, especially in that model when you've got a lot of healthcare workers out in the field. If it's not the typical sort of malaria, if it's not the sort of typical diarrheal illness, then how do you manage it? And so I think that's been our focus primarily, has been on educating the doctors. But you're right, educating lots of healthcare workers is also really important. So.
We have an example along those same lines. It's one of the more successful programs for global health. It's been Academy of Pediatric section of perinatal medicine, where they focus on use of low technology, simple bag mask, room air, not all the fancy neonatology medications, and training mostly non-physicians who are out the midwives in the rural hospitals, et cetera, to really improve resuscitation.
Yeah, helping babies breathe, I think, is the program, which is incredible. And I've seen, absolutely, and we've done it in Liberia too, with the helping babies and training midwives in particular to be able to resuscitate babies. Absolutely, absolutely.
If you look at the mortality and what they have done, if you look at the mortality from diarrheal diseases, which used to be the biggest thing that you see in the map of the India or some other countries, just going out and with the ORS or oral readdressing solutions and working with these things on, you don't need a fancy medical knowledge and
That's
differential
exactly right.
diagnosis. Because to save the life, you need to have just the local people work on things on. And I think if you looking at the mortality and morbidity point of view, yes, I think the primary care and treating that thing comes up first, and that can be easily achieved with just the creating the force of the social service worker or worker from the population, which is hard to come by. They have a lot more barriers, and we don't want to go into detail and go to the rest of the people. But
No, you're absolutely right. And I think as much as you can push that out to lower level health workers and to rural populations, you're going to have a big impact. And immunizations are a great example of that too, right? So, absolutely.
Jackson, thank you. Great talk.
Thank you.
You might want to, just for the benefit of the audience, to describe the fact that when the war ended, I think it was around 2004, there was a huge emphasis on just what you're saying, Dr. Shah, training local health workers. So in Liberia, before these projects were taking off, that was the main emphasis, was training local health workers, reopening, some of the destroyed. I think 3/4 of all health facilities were destroyed in the war. A quarter of men were killed, and half of the women were raped in the war.
Right.
There's just huge trauma, both physical and psychological, in this country. It's amazing. But the emphasis by the global community was to build up the primary care and community health worker. And this is really kind of the next phase of building. So it's an interesting aspect of helping a system rebuild, helping a country rebuild its healthcare system.
Absolutely. And we're trying to train the trainers, really. So to train the next generation of doctors who will then go out and train that next cohort of community health workers. Absolutely. Well, thank you all for your attention and time. I appreciate it.
Wonderful talk. Thank you.